If you have ever been, prepared for surgery or perhaps just took a really potent cold remedy and suddenly found yourself struggling to swallow,
Right.
feeling like your throat and your mouth were just completely dry, or maybe you realized you couldn't focus on your phone screen, you've experienced something pretty profound.
You absolutely have.
Yeah.
You've encountered the surprising and, well, powerful effect of manipulating your own involuntary nervous system.
Mhm.
Those inconvenient, sometimes even kind of alarming side effects
Mm.
are our body's internal switches being flipped.
Yeah, that's exactly where we're going.
Today, we are diving deep into the world of anticholinergic drugs and other agents that act on autonomic ganglia, the chemicals that, pull the levers on everything we don't consciously control.
Right. The dry mouth, the constipation, that specific type of blurry vision, it all leads back to this class of compounds that block acetylcholine. So our mission in this deep dive is to unpack your sources, to really understand how these agents work at a molecular level, classify the different types from the really broad blockers to the surgical precision tools, and explore the surprisingly broad effects they have across the body.
All the way from the brain to the bladder.
From the brain to the bladder. We want you to walk away with a shortcut to being truly well-informed about this really potent class of pharmaceuticals.
And to start, we absolutely have to tackle a crucial distinction in the terminology.
Okay.
When we talk about anticholinergic drugs conventionally, especially in a clinical setting, we're strictly referring to those that block the actions of acetylcholine or H on autonomic effectors and the CNS through muscarinic receptors.
Muscarinic.
Because they essentially stop or break down the function of the parasympathetic system, they're also known as parasympathetic drugs. Auritic, meaning, stopping or dissolving, or just simply atropinic drugs, named after the prototype.
Okay, so if I hear anticholinergic, I should primarily be thinking of drugs that target the muscarinic side of the house, basically putting the brakes on the entire rest and digest system.
Precisely. Now, drugs that block the other major type of AONE receptor, the nicotinic receptors, they're categorized separately.
Right.
When they block the ganglia, we call them ganglion blockers. When they block the neuromuscular junction, they're neuromuscular blockers.
So for this deep dive, we're going to separate them into those two main groups.
We have to. The muscarinic blockers and the nicotinic blockers, because their clinical applications and their effects are just dramatically different.
Okay, let's unpack this, starting with the muscarinic side and the original blueprint compound, one of the oldest known active drugs derived from nature, atropine.
Atropine is the undisputed prototype, and its history is, as dark as it is fascinating. It's a natural alkaloid found in plants of the Solanaceae family, like deadly nightshade, Atropa, belladonna, and datura.
And the name belladonna itself, beautiful lady, that comes from the historical practice of women using the plant extract to dilate their pupils, right?
Exactly, to make them appear more beautiful.
Yeah.
But what makes it a pharmaceutical prototype is its exquisite chemical selectivity.
How exactly can we measure that selectivity? How do we know it's so specific?
It's actually very neat in the lab. If you take a piece of tissue, say a guinea pig ileum, atropine acts as a competitive antagonist. It selectively blocks the contractions caused by acetylcholine.
Just this acetylcholine.
Just the ACA. Crucially, it leaves contractions that are evoked by other smooth muscle spasmogens, like histamine or 5-HT, completely unaffected.
Wow.
And that's the definition of selectivity in pharmacology. It knows exactly which key it's supposed to block from entering the lock.
And it's a competitive antagonist, meaning it's literally fighting AC for that spot on the receptor. We should also emphasize that atropine, famously, blocks all three major muscarinic receptor subtypes, M1, M2, and M3, which is what explains its massive systemic impact.
That's the key structural takeaway. And one final note on its action. While it is highly selective at therapeutic doses, if someone takes a dangerously high toxic dose, that selectivity can start to be lost.
It gets messy.
You begin seeing non-specific effects. But for our purposes, we treat it as the broad-spectrum muscarinic blocker.
So let's delve into the sheer scope of this prototype drug. As you mentioned, since atropine blocks M1, M2, M3, we can essentially predict its effects by just imagining what happens when the parasympathetic system is fully paralyzed.
Exactly.
Where that system is most active, the effects of atropine will be the most prominent.
Precisely. We see the most profound responses in organs that normally receive strong parasympathetic tone. The heart, the glandular secretions, gut motility, and the eye.
Let's start with the CNS, because the effects of the parent compound, atropine, are so often confused with its better-known relatives. What is atropine's primary action in the central nervous system?
So atropine generally has an overall CNS stimulant action.
Stimulant.
Stimulant, yeah.
Yeah.
However, at low therapeutic doses, the central effects are minimal.
And why is that?
It's purely a pharmacokinetic issue. Atropine is a tertiary amine, but its entry into the brain via the blood-brain barrier is still pretty restricted compared to some of its close cousins.
So if I take a small dose for, say, a peripheral issue, I shouldn't expect a dramatic mental change.
Not initially, no. But as the dose increases, atropine starts to stimulate key medullary centers, the vagal, the respiratory, and the vasomotor centers.
Okay.
If the dose gets high enough, that is when the dramatic effects kick in. You get significant cortical excitation, which leads to restlessness, disorientation, full-blown hallucinations, delirium.
Wow.
And this is followed eventually, and very dangerously, by respiratory depression and coma. This is that mad as a hatter stage of poisoning.
And that sets the stage perfectly for a comparison with its famous relative, hyoscine, which is also known as scopolamine.
Right.
Hyoscine has a completely opposite central depressant effect, even at very low doses.
That is the crucial chemical difference. Hyoscine is also a tertiary amine, but it has much better lipid solubility. So it has superior blood-brain barrier penetration.
It gets into the brain much more easily.
Much more easily and rapidly. This allows it to access the CNS, where it produces these central depressant effects like amnesia, fatigue, drowsiness, and promoting NREM sleep. The contrast couldn't be starker. Atropine excites the cortex, hyoscine sedates it.
And that profound central action is what explains its utility in motion sickness, correct?
Absolutely. Hyoscine is extremely effective because it depresses the vestibular excitation that triggers motion sickness. In fact, if you compare it to atropine, which only gets a rating of, say, 2 pluses for anti-motion sickness,
Okay.
hyoscine is consistently rated 3 pluses. It's the standard for those transdermal patches you see.
And we should also briefly touch on the application in Parkinsonism, since Parkinson's involves a relative cholinergic overactivity in the basal ganglia.
The dopamine deficiency, basically.
Right, so atropine substitutes are used to rebalance that dopamine-H ratio, reducing tremor and rigidity.
It's a classic example of using anticholinergics to restore balance in a motor system where one neurotransmitter AC is functionally dominated because of the deficiency of its counterpart, dopamine. It really shows how M1 receptors in the CNS are critical modulators of movement control.
Okay, moving to the cardiovascular system. This is where we run into one of the most intellectually satisfying contradictions in pharmacology, the paradox of the heart.
Yes.
The main effect is tachycardia, a fast heart rate, which is logical. You block the M2 receptors on the SA node, you remove the vagal brake that usually slows the heart.
Correct. And that tachycardia is directly proportional to the existing vagal tone.
Meaning?
Well, if you're a young, healthy adult with high vagal tone, atropine will cause a much more marked increase in your heart rate than it would in, say, an elderly individual with naturally lower vagal tone.
But the paradox is the initial effect. Right after injection, especially with a rapid whole V administration, the heart rate sometimes drops transiently. It slows down before it speeds up. How can a vagal blocker cause a temporary bradycardia?
This is where we shift from viewing the system as a simple on-off switch to understanding its really complex modulated controls. For a long time, the cause was debated, but now the consensus is strong.
And what is it?
It's caused by the blockade of release-inhibitory muscarinic autoreceptors, M1, located right on the vagal nerve endings themselves.
Okay, so autoreceptors are receptors that respond to the transmitter released by the same neuron.
Exactly.
So the vagal nerve releases AG, and that AC normally circles back and hits these M1 autoreceptors. Is that right?
That's precisely right. These M1 autoreceptors normally function as a self-regulating braking system. When the nerve fires rapidly and releases a lot of AC, that AC hits these autoreceptors, which then signals the nerve ending to reduce further AC release. It's a classic internal negative feedback loop.
So when atropine is first introduced, it gets in there and it blocks that M1 autoreceptor.
Yes, and by blocking that M1 receptor, atropine removes the brake on AC release. The nerve ending suddenly releases more acetylcholine than it would normally, just for a brief period.
Oh.
And this surge of natural HE temporarily overwhelms the system, causing that initial transient bradycardia before the atropine fully dominates the M2 receptors on the SA node and the heart rate skyrockets.
That is truly insightful. So the initial bradycardia isn't due to atropine blocking the parasympathetic system. It's due to atropine accidentally boosting the parasympathetic signal by removing its own self-inhibition.
And we know this is a specific M1 effect because if you administer a selective M1 antagonist, like pirenzepine, it causes that initial bradycardia with equipotent force to atropine, even though pirenzepine has far less action on the cardiac M2 receptors.
A beautiful demonstration of local receptor modulation.
It really is.
So beyond heart rate, what are the other consequences in the cardiovascular system?
Well, atropine facilitates AV conduction, and it shortens the PR interval, which can be beneficial, particularly if a patient's conduction was depressed by high vagal tone, like in certain cases of myocardial infarction.
And what about blood pressure?
Regarding blood pressure, since vascular tone is primarily maintained by sympathetic adrenergic impulses, not cholinergic ones.
Right.
Atropine has no consistent or marked effect on BP, at least at therapeutic doses.
Okay, moving to the ocular effects. This is maybe the most famous and historically the most problematic systemic consequence. I mean, the 7 to 10-day duration of action is just astonishing.
The ocular effect is the classic triad that defines anticholinergic action. A topical installation causes mydriasis, which is extreme pupil dilation,
Right.
abolition of the light reflex so that people won't constrict when light hits it, and most importantly, cycloplegia.
And cycloplegia is the paralysis of accommodation.
Exactly. It's the paralysis of the ciliary muscle, for which you need to change the shape of your lens and focus on near objects. This results in severe photophobia and, blurring of near vision.
And why is the effect so long-lasting? 7 to 10 days is a long time.
It's because once atropine is sequestered in the tissues of the iris and the ciliary body, it's just released very, very slowly. This long duration makes it completely impractical for simple diagnostic exams, which is why specialized shorter-acting compounds were invented later.
And what's a critical risk here?
Intraocular tension tends to rise. This is a crucial risk factor, especially for any patient who has narrow-angle glaucoma. The dilated iris can physically block the outflow drainage channels, precipitating a painful and blinding acute congestive glaucoma attack.
A true emergency.
A true emergency.
Okay, now to the internal workings. Smooth muscles in the viscera and the airways. Blocking the parasympathetic system here means relaxation, which results in that universally inconvenient side effect, constipation.
Yes, we see relaxation of virtually all visceral smooth muscles receiving parasympathetic innervation, and that's primarily through M3 receptor blockade. This reduces both the tone and the amplitude of contractions in the stomach and intestine, slowing the passage of food and potentially causing some pretty obstinate constipation.
But the sources emphasize that peristalsis is only incompletely suppressed. Why is the gut so resistant to a total shutdown?
This is a major insight into the sophistication of the enteric nervous system. Peristalsis is not solely driven by a T input from the vagus nerve.
That's not that simple.
It's not. It is primarily regulated by local reflexes operating within the enteric plexus, that second brain in the gut wall.
And those local reflexes use a bunch of other neurotransmitters.
Precisely. They involve a complex interplay of non-cholinergic transmitters like 5-HT, enkephalin, various peptides. Atropine only blocks the cholinergic input.
Ah.
So while atropine can effectively antagonize motility if it's caused by an injected cholinergic drug, it's much less effective against the natural intrinsic activity of the gut, which uses this vast array of co-transmitters.
The system has built-in redundancy.
It does, preventing total paralytic ileus unless the dose is extremely high.
In the respiratory system, though, this relaxant action is highly valuable, particularly in pulmonary disease.
Oh yes. Atropine causes significant bronchodilation and reduces airway resistance. This is incredibly valuable in conditions like COPD and asthma. And the mechanism isn't just direct muscle relaxation. It also attenuates the reflex vagal component that's often heightened by inflammatory mediators.
So when inflammatory agents like histamine or prostaglandins are released, they trigger a reflex via the vagus nerve that tightens the bronchi. By blocking the AC part of that reflex arc, atropine helps keep the airways open.
It's an essential clinical tool for that reason. Though, as we'll get into, atropine itself has been replaced by more selective inhaled quaternary compounds that avoid all those systemic side effects.
Let's cover the urinary tract. Blocking the smooth muscle here has some very serious implications, especially for older patients.
Absolutely. Atropine causes a relaxant action on the ureter and, critically, the detrusor muscle of the urinary bladder.
The benefit being?
The benefit is clear. It can increase bladder capacity and control the involuntary detrusor hyperreflexia that causes that feeling of urgency and frequency. However, the dangerous consequence is the risk of urinary retention.
And this is especially severe in elderly males.
It is because they often have concurrent prostatic hypertrophy. The bladder is relaxed, but the sphincter is tightly closed. It's a recipe for disaster.
Now, for the most famous systemic actions, glandular secretions and body temperature, this is where the patient really feels those classic side effects.
Atropine is a master desiccant. It markedly decreases virtually all major secretions, primarily via M3 receptor blockade, sweat, salivary tracheobronchial, and lacrimal secretions.
And the consequence is immediate.
Immediate and often unpleasant. Dry skin, difficulty talking and swallowing, and dry eyes.
Is it useful for gastric acid secretion?
It does decrease acid, pepsin, and mucus secretion, but its effect is predominantly on the volume of secretion. To significantly reduce the acid concentration, you need very high doses, and even then, it is dramatically less effective than the modern H2 blockers or proton pump inhibitors.
So the PPIs.
The PPIs. This failure to fully suppress acid is another reason it was really relegated in GI treatment.
And finally, the life-threatening consequence in children, atropine fever. Why are children so susceptible to a dangerous rise in body temperature?
The mechanism here involves two complementary actions that occur at higher systemic doses. First, the most obvious one, inhibition of sweating, which physically prevents the body from cooling itself via evaporation.
Makes sense.
Second, and less intuitively, there is a stimulation of the temperature-regulating center located in the hypothalamus.
So it's a double whammy.
It is. These two actions combine to make children extremely susceptible to dangerously high fever, where their thermal regulation completely fails. The combination of hot as a hair and dry as a bone can be lethal in infants.
To bring all these disparate effects together, let's use the source material's gradient of organ sensitivity. This helps us visualize which effects will appear first as the dose slowly increases.
It's a very useful hierarchy, and it reflects the varying dependence on cholinergic tone. The functions that require the smallest dose of atropine to block are the most sensitive.
So the order, from most sensitive requiring the lowest dose to least sensitive requiring the highest doses: salivary, sweat, and bronchial secretions.
The glands go first.
The glands go first, then the eye, bronchial muscle, and heart. Then the smooth muscle of the intestine and bladder.
And finally, last on the list,
The gastric glands and smooth muscle.
this gradient perfectly explains the patient experience. The very first thing a patient notices when taking an anticholinergic drug is dry mouth and dry eyes, which requires the lowest systemic dose. The very last thing to be significantly affected is gastric acid production or gut motility.
Since atropine is so non-selective and broad-blocking M1, M2, M3 everywhere, it created an absolute necessity for chemists to invent more selective substitutes.
It did. The goal was to target one function like the lungs or the bladder, while minimizing all those inconvenient, sometimes dangerous systemic side effects like cycloplegia, dry mouth, and urinary retention.
This is where chemical modification steps in, and we can group these substitutes by their fundamental structural changes.
The first major group are the quaternary compounds.
Okay, and these compounds have a specific chemical structure that prevents them from crossing lipid membranes easily, which means they focus their action almost entirely outside the central nervous system.
Exactly. Their quaternary structure imparts four key common characteristics which are vital for you to grasp. First, they have incomplete oral absorption, often only 10 to 30%.
So not great if you take it as a pill.
Not great. Second, they have extremely poor penetration of the brain and the eye, which is a major benefit.
Right.
It means you don't get central excitation or severe ocular effects from oral dosing. Third, they tend to be significantly longer acting than atropine.
And the fourth characteristic is the trade-off, where the chemical structure starts to look like agents that block nicotinic receptors, and that brings a new risk.
That's the critical point. They inherently have a higher nicotinic blocking property. This means that at clinical doses, they may cause a degree of ganglionic blockade.
Which leads to a whole new set of side effects.
Exactly. Unwelcome side effects like postural hypotension, where your blood pressure suddenly drops when you stand up, and critically, impotence. These risks are why oral quaternary compounds have generally fallen out of favor for chronic use.
But let's look at the success story where this peripheral targeting is a major advantage: respiratory selectivity. We're talking about ipratropium and tiotropium, which are crucial for COPD management.
Ipratropium bromide is an inhaled quaternary compound. It acts selectively on the bronchial muscle, providing bronchodilation. The genius of its structure is that because it is inhaled and it is a quaternary compound, it stays localized in the lungs and doesn't cause those systemic side effects.
What about mucociliary clearance? That's so important for COPD patients who are already struggling with mucus.
It's a massive benefit. Unlike atropine, ipratropium does not depress mucociliary clearance.
That's key.
It's key for maintaining lung hygiene. Clinically, ipratropium is more effective in COPD, where that fixed parasympathetic tone is a dominant factor than it is in acute asthma. But you have to note its kinetics.
It's slow.
It has a gradual onset and a peak action that occurs 40 to 60 minutes after inhalation. This makes it a prophylactic, regular-use drug, not a quick rescue inhaler.
And then tiotropium came along and basically fixed the convenience issue.
Tiotropium bromide is the evolution. It's a congener that was designed for maximal residence time in the lungs. It binds exceptionally tightly to both bronchial M1 and M3 receptors.
And that tight binding means it's released very slowly.
Very slowly from the receptors, resulting in highly effective and long-lasting bronchodilation.
That long residency is what allows for the convenience of once-daily maintenance therapy in COPD.
Exactly. And it confers a relative M1-M3 selectivity because its binding to the M2 receptor is weaker, which allows it to dissociate more quickly from that one. This tight, long-lasting binding is what differentiates it from ipratropium.
Okay, next, let's pivot to the eye and the need for paralyzed mydriatics and cycloplegics that don't blur your vision for 10 days.
Right.
The goal here is duration control.
When a doctor needs to conduct cycloplegic refraction, which is measuring the eye's focusing power without the interference of the patient's own ciliary muscle contraction, they need paralysis, but they need it to wear off quickly.
So how do the substitutes provide that duration control?
We use a scale of duration. Homatropine is about 10 times less potent than atropine, and it lasts 1 to 3 days. Its cycloplegia is often unsatisfactory, especially in children whose ciliary muscle tone is very strong.
Okay.
Then you have cyclopentolate. It's potent, rapid-acting in 30 to 60 minutes, and it lasts about a day. This is generally the preferred one for cycloplegic refraction in most adults.
But cyclopentolate carries that risk of CNS side effects, especially in children, if it gets systemically absorbed.
It does. The drug can drain through the nasolacrimal duct and right into the systemic circulation. In children, this can lead to transient behavioral abnormalities, disorientation, even psychosis. So caution is required, particularly with the dosage.
And for a quick temporary dilation, maybe for a simple fundoscopy.
That's where tropicamide shines. It is the quickest agent, acting in 20 to 40 minutes, and the briefest, lasting only 3 to 6 hours.
But the cycloplegia is unreliable.
It's unreliable, but it's perfectly satisfactory for adult refraction, where a quick temporary dilation is all that you need.
Okay, let's discuss the highly modern application. Vasicose-selective anticholinergics. These are the drugs that target the bladder to treat issues like urinary frequency and urge incontinence.
This represents significant therapeutic progress. These drugs are necessary because using atropine for urinary urgency would cause dry mouth, constipation, and blurry vision long before it achieved any reliable bladder relaxation.
So the innovation here is developing agents with a relative selectivity for the M3 receptor subtypes.
Yes, which are highly dominant in the detrusor muscle of the urinary bladder.
What are the primary agents used?
Well, the first notable agent was oxybutynin. It has a high affinity for both bladder receptors and, unfortunately, salivary gland receptors.
So still a lot of dry mouth.
Still a lot of dry mouth. It also has additional smooth muscle relaxant and local anesthetic properties. It's effective in neurogenic bladder, enuresis, and post-prostatectomy spasm.
But the high incidence of anticholinergic side effects really limits patient compliance. And we should note, it's metabolized by the CYP3A4 enzyme, a common drug interaction concern.
So the newer agents were designed specifically to reduce that salivary gland affinity.
Exactly. Tolterodine was developed to be relatively M3 selective. It demonstrates a preferential action on the bladder wall, which results in a lower incidence of dry mouth compared to oxybutynin.
And then we have the even more advanced agents.
Right, davinasen and sulfonylurea. And these two are highly regarded because they combine that M3 selectivity with a really convenient duration of action.
They are powerful and effective.
Yeah.
They're also relatively M3 selective, but their key feature is their long half-lives. Darafenicin's half-life, for instance, ranges from 13 to 19 hours.
Which allows for once-daily dosing.
Highly convenient once-daily dosing. This significantly improves patient adherence to a long-term treatment plan for a chronic condition like urgency.
Finally, let's revisit a unique, historically important synthetic compound, Pirenzepine. It was unique because it was highly M1 selective.
Pirenzepine was fascinating. It was one of the first truly selective anticholinergics. It was designed to inhibit gastric acid secretion, which it did, without causing the typical dose-limiting side effects like dry mouth and blurred vision.
And that's because those are primarily M2 and M3 effects.
Exactly.
So why was blocking M1 thought to inhibit gastric secretion?
This is a crucial distinction from modern PPIs. Pirenzepine's site of action was likely not the parietal cell itself, the acid-producing cell, but rather the intramural plexuses and ganglionic cells within the gut wall.
So it was thought to modulate the nerve input to the parietal cells.
Precisely. It worked by dampening the neural trigger for acid production rather than shutting down the final proton pump mechanism itself. It was an indirect modulator.
But its use declined pretty rapidly.
It did, once H2 blockers and especially PPIs came out, because PPIs block the final common pathway for acid secretion directly at the parietal cell. They're just far superior and more reliable than modulating the complex neural network with pirenzepine.
And one final synthetic agent, dicyclomine. What's its unique dual mechanism?
Dicyclomine has two actions. A weak anticholinergic effect, which is somewhat M1 selective, combined with a direct, non-specific, smooth muscle relaxant action. This dual property makes it a highly effective antispasmodic for conditions like irritable bowel syndrome or even morning sickness.
We had a safety note about this drug regarding infants. Let's make sure we elaborate on why it's contraindicated in very young patients.
Yes, it is absolutely not recommended for infants under 6 months of age. While the drug is meant to relieve infant colic and gas, infants are extremely sensitive to the anticholinergic effects of the drug.
So the risk of toxicity is high.
The risk of systemic absorption and the potential for severe entropenic toxicity symptoms, fever, respiratory distress, delirium, it significantly outweighs the benefit in that population.
Now that we understand the pharmacology of these agents, we can clearly delineate their necessary therapeutic applications.
Right. And generally, they are used to block an unwanted action, contraction, secretion, or unwanted vagal input.
Let's start with anti-secretory uses. Pre-anesthetic medication is a classic use, although its necessity has changed over time.
Historically, it was absolutely essential, especially when volatile, irritant general anesthetics like ether were common. They caused a flood of tracheobronchial and salivary secretions.
A huge problem for the anesthetist.
A huge problem. So you needed an anticholinergic to check them. Even though modern, non-irritating anesthetics have reduced the necessity, anticholinergics like glycopyrrolate, a quaternary compound, are still routinely used.
Why glycopyrrolate specifically?
Glycopyrrolate is preferred because it is potent, it's long-acting, and crucially, because of its quaternary structure, it does not cross the blood-brain barrier.
So no CNS side effects.
Exactly. And it prevents the two critical reflexes we worry about. Vasovagal attacks, those sudden drops in heart rate and blood pressure, and laryngospasm, which is often reflexively predisposed by excessive secretions irritating the larynx.
And we noted its use in unexpected emergencies like pulmonary embolism.
Yes, atropine can be beneficial by reducing the massive pulmonary secretions that are reflexly evoked by the embolism. It provides symptomatic relief and can potentially improve oxygenation.
And of course, a simpler application is just to control excessive sweating or salivation.
Right, like the drooling in some Parkinson's patients where the central anticholinergics can help.
Moving to antispasmodic applications like in intestinal or renal colic.
They do offer symptomatic relief by relaxing the spasmodic smooth muscle of the ureter or intestine. However, in severe renal colic, we must be very clear that anticholinergics are secondary.
They're not the first line of defense.
Not at all. Parenteral opioids and NSAIDs are necessary and provide significantly greater pain relief by addressing the underlying cause of the pain and inflammation. But for less severe conditions like abdominal cramps or IBS, they are highly effective.
And the vasoselective drugs are the standard of care for relieving urinary frequency and urgency.
They are.
The ocular therapeutic use of atropine is highly specific, and this is separate from simple diagnostics.
It is invaluable in inflammatory conditions like iritis, keratitis, and corneal ulcer. Here, the long-lasting mydriatic and cycloplegic action serves a vital therapeutic function.
Which is what?
It gives complete rest to the intraocular muscles, and it relieves the painful spasm caused by the inflammation. Furthermore, by keeping the pupil dilated, it prevents or breaks up the formation of adhesions, or synechia, between the iris and the lens.
And the cardiac vagolytic use is about selective rescue.
Yes, selectively removing the brake on the heart. It is useful in counteracting sinus bradycardia and partial heart block in selected patients where increased vagal tone is identified as the clear cause.
Like after a heart attack.
Common after an acute myocardial infarction, or sometimes when a patient is suffering from digitalis toxicity. Atropine essentially serves as an emergency accelerator pedal.
And finally, the most dramatic life-saving application, antagonizing poisons.
Atropine is the specific, essential antidote for poisoning by acetylcholinesterase inhibitors, or anti-SHE poisoning, which includes things like nerve agents and certain pesticides. It blocks the massive flood of excessive cholinergic stimulation that overwhelms the system.
And also mushroom poisoning.
It is also the antidote for early mushroom poisoning caused by species that contain muscarine.
Okay, now we have to address the flip side. Side effects and toxicity, specifically belladonna poisoning. Since the symptoms are just exaggerated pharmacology, how should you remember the classic signs?
Well, the symptoms are indeed just the exaggerated pharmacological actions of the drug. To remember the manifestations, there's a clinical mnemonic often used that summarizes the core systemic failures.
Okay.
You see dry mouth and difficulty talking or swallowing, dry, flushed, and hot skin accompanied by fever, difficulty in micturition or urination, and the fully dilated pupil with photophobia and blurred vision. The famous rhyme encapsulates it all. Hot as a hare, blind as a bat, dry as a bone, red as a beet, and mad as a hatter.
And when the dose is truly toxic, what are the severe life-threatening symptoms?
The central effects become dominant. Extreme excitement, frank psychotic behavior, full-blown delirium, and terrifying visual hallucinations.
And peripherally.
Peripherally, you observe hypotension, a rapid pulse that can progress to arrhythmia, and eventually cardiovascular collapse.
If a patient presents with this complex array of symptoms, how do clinicians confirm that the cause is anticholinergic poisoning and not something else?
The diagnosis relies on pharmacological failure. Since the muscarinic receptors are completely blocked, if you administer a classic cholinergic agonist like methacholine or an anticholinesterase like neostigmine,
Nothing happens.
they will fail to induce the expected muscarinic effects, like salivation or gut motility. That failure of response is definitive.
And what's the modern treatment approach?
Treatment is primarily supportive and symptomatic. The patient has to be placed in a dark, quiet room to manage the central excitation and hallucinations. Crucially, cold sponging or ice bags must be used to aggressively reduce the potentially lethal fever.
And what about an antidote?
Historically, physostigmine was used because it can cross the blood-brain barrier to antagonize both central and peripheral effects. However, due to the significant risks it carries, specifically hypotension and fatal arrhythmias, it is generally not recommended today, unless the poisoning is life-threatening and supportive measures are failing. Most cases recover with excellent supportive care.
Moving to strict contraindications, what conditions make these drugs absolutely unsafe?
The absolute contraindication is any individual with a narrow iridocorneal angle.
Right, because of the glaucoma risk.
As we discussed, the drug risks precipitating acute congestive glaucoma, which is an emergency. Extreme caution is also strongly advised for elderly males with existing prostatic hypertrophy due to the high and severe risk of urinary retention.
Finally, drug interactions. How do anticholinergics alter the pharmacokinetics and pharmacodynamics of other drugs?
They interact in critical ways, primarily through delaying gastrointestinal transit. Since atropine slows gastric emptying, the absorption rate of most orally administered drugs is slowed. A critical example is levodopa, where delayed absorption means less of the drug reaches the brain to treat Parkinson's symptoms.
But the sources noted a counter effect, increased absorption for some drugs.
Yes, that's the exception. For drugs like digoxin and certain tetracyclines, their extent of absorption may actually be increased.
Why is that?
Because the longer GI transit time provides more surface area and more time for them to be dissolved and absorbed effectively. And the simplest interaction, of course, is just additive side effects.
Right.
When anticholinergics are combined with other drugs that already have anticholinergic properties like antihistaminics, TCAs, or phenolthiazines, the side effects, especially dry mouth and confusion, are dramatically multiplied.
Now we make a complete transition, moving away from muscarinic receptors on effector organs and heading to the autonomic ganglia, where nicotinic receptors, the NN subtype, reign supreme.
This shift takes us into a much more complex area of neural control. The autonomic ganglion is not just a simple relay station where AC fires a signal across.
It's more than just a switch.
Much more. While AC is the primary excitatory neurotransmitter acting rapidly on the NN receptors to depolarize the postganglionic neuron, the system is deeply modulated.
How complex is this modulation?
Extremely complex. The rapid NN signal is overlaid by secondary, slower modulatory changes mediated by an entire cocktail of other receptors, including M1 and M2 muscarinic receptors, as well as adrenergic, dopaminergic, and peptidergic receptors.
So the ganglion is really a sophisticated local processing center.
It is. It's capable of filtering and adjusting the signal before it reaches the final target organ.
And the most famous agent that interacts here is nicotine itself, the quintessential ganglionic stimulant.
Nicotine is the principal tobacco alkaloid, and it acts as a powerful agonist. It acts not only on the NN, or ganglionic subtype, but also the NM, the neuromuscular subtype.
So it's a widespread stimulant.
Initially, yes, of both sympathetic and parasympathetic ganglia simultaneously. However, this stimulation is dose-dependent. At high concentrations, nicotine causes persistent depolarization, which quickly leads to a functional blockade of the ganglia.
Given that it fires both major control systems at once, sympathetic, fight or flight, and parasympathetic, rest and digest, it sounds like an utter chaos agent in the body.
It is, which is why there is virtually no general therapeutic application for ganglionic stimulants. Stimulating both sympathetic and parasympathetic ganglia concurrently serves no useful purpose.
The only clinical use is replacement therapy.
The only clinical utility for nicotine itself is in the context of short-term replacement therapy for tobacco abstinence.
Let's focus on that therapeutic application in smoking cessation, because this is a huge area of modern pharmacology where we see some incredible targeted drug design.
Nicotine replacement therapy, or NRT via patches, gum, or lozenges. It works by ameliorating the most severe physical withdrawal symptoms, but it has a major limitation in addressing addiction. It only partially suppresses the craving because it cannot reproduce the intermittent, high-peak nicotine blood levels that a smoker achieves with an inhaled puff. It gives steady relief, but not that high-reward hit.
And that brings us to varenicline, or Chantix, which is a major innovation because it targets the specific reward pathway.
Varenicline is fascinating. It's a selective partial agonist at the alpha-4 beta-2 subtype of neuronal nicotinic receptors.
Okay, that's specific.
Very specific. And these alpha-4 beta-2 receptors are heavily concentrated in the brain's mesolimbic system, including the nucleus accumbens, which is the primary reward center.
As a partial agonist, varenicline is clever. It binds tightly to the receptor, but it only provides a low-level partial activation, right?
Exactly. This partial activation is enough to induce a steady, low-level dopamine release in the reward center. It provides substitution and reduces withdrawal symptoms, a low, steady feeling of satisfaction.
But the real genius is that by occupying the receptor, it acts as a functional antagonist against nicotine.
That's the key. So if the user tries to smoke while taking varenicline, the natural nicotine, the full agonist, can't bind to the receptor.
The full massive reward effect of smoking is blocked.
It's blocked. Varenicline provides substitution while simultaneously blocking the high-impact reward mechanism, effectively demoting the pleasure of smoking. Clinically, it reduces both craving and withdrawal symptoms.
However, this drug that targets the deep reward centers of the brain comes with some very serious warnings.
It does. Because it manipulates key central pathways, varenicline is associated with severe neuropsychiatric side effects. These include marked mood changes, agitation, hostility, and irrational behavior.
And the source notes a suicide risk.
The source clearly notes the explicit warning that it may promote suicidal ideation and actions, requiring very careful monitoring by prescribers. This really highlights the delicate, sometimes dangerous connection between autonomic receptors and deep cognitive function.
Are there non-nicotine options for smoking cessation that avoid this direct manipulation of the nicotinic receptor?
Yes. Bupropion is a very effective alternative. It is an atypical antidepressant that is thought to exert its effect in this context by inhibiting the neuronal reuptake of dopamine and norepinephrine.
So it boosts those catecholamine.
Yes, it increases their concentration in the synapse, mimicking the effects of nicotine on the reward pathways, but via an entirely different mechanism. Clinically, bupropion has been rated as equivalent in efficacy to NRT, offering a viable, non-nicotine path for cessation.
Finally, let's revisit the ganglionic blocking agents, the original nicotinic antagonists. These are essentially obsolete as drugs, But as you mentioned, they are invaluable teaching tools.
The competitive blockers, like hexamethonium and trimethophan, were used for hypertension and peptic ulcers back in the 1950s. They worked, but they produced a truly intolerable array of side effects because they paralyzed every single organ controlled by the autonomic nervous system,
So they were replaced.
completely replaced by more selective drugs.
So why do we still study them?
Because they illustrate the relative dominance of the sympathetic and parasympathetic divisions on different organs. By observing the consequence of total paralysis at the ganglion, we can infer which system maintains the resting tone for that organ.
Okay, let's run through that lesson using the table of dominance. Start with the cardiovascular system.
For the heart, parasympathetic tone is dominant. Therefore, ganglionic blockade removes the brake, causing immediate tachycardia.
And the blood vessels.
For the arterioles and veins, sympathetic tone is overwhelmingly dominant. Therefore, ganglionic blockade removes that tone, causing marked vasodilation and severe postural hypotension. This side effect is precisely what made them clinically useless for hypertension.
What about the gut and bladder?
The gastrointestinal tract and the urinary bladder are dominated by the parasympathetic system. Therefore, blockade causes decreased motility constipation and difficulty in micturition due to the relaxation of the detrusor muscle.
And the glands.
Salivary, lacrimal, and sweat glands are parasympathetic dominated. Blockade causes dry mouth and anhidrosis, the inability to sweat. And conversely, the sweat glands are dominated by the sympathetic system, but the postganglionic transmitter is a she. A weird exception. Blockade still causes anhidrosis.
So it's a complete reverse engineering of the nervous system. By blocking the master switch, we can clearly see which system was winning the tug of war for control of that specific organ.
Precisely. There are historical failures as medicines, but remain excellent pedagogical tools for understanding autonomic physiology.
This has been an incredibly deep exploration of the chemical levers that control our involuntary life. We covered the crucial distinction between muscarinic and nicotinic antagonists, understood the broad, historical, and potent effects of the prototype, atropine,
Right.
from the initial paradox of heart rate, where it briefly boosted the vagus nerve, to the massive list of peripheral side effects that forced pharmacologists to seek selective agents.
And we saw the essential genius of pharmaceutical chemistry in creating these highly specialized synthetic drugs. The quaternary compounds like tiotropium, designed to relax the bronchi once daily without ever leaving the lungs.
And the vasoselectives that now treat urinary urgency while minimizing generalized anticholinergic side effects.
You now have a detailed molecular and clinical understanding of how these pharmaceutical agents serve as precise tools to manipulate the fine balance of our involuntary nervous system.
And we ended by discussing the agents used for smoking cessation, particularly varenicline, which works not just by substituting nicotine, but by manipulating the critical dopamine-driven reward pathway located deep in the brain's mesolimbic areas.
And this convergence of control mechanisms, autonomic function influencing cognitive function, leads us to our final thought for you to explore. We saw that scopolamine, an atropine relative, had such profound depressant and amnesic actions that it was historically explored as a potential truth serum. Similarly, we found that varenicline can promote serious mood changes and agitation by subtly activating the reward pathway. Given the critical role of the M1 receptor in both the autonomic ganglia and the basal ganglia, and its known involvement in learning and memory in the cortex.
So it's everywhere.
It's everywhere.
Yeah.
What deeper secrets about human behavior, cognition, and emotional processing might be unintentionally revealed or influenced as we develop even more selective drugs that target specific modulatory receptors like M1 that exist in the complex network connecting involuntary control with a conscious mind? What remains hidden within the complex interaction of our autonomic and central systems that we have yet to truly harness or fully understand?